Welcome to Scrubcast, where we take a closer look at the research happening at Stanford University's Department of Surgery. I'm your host, Rachel Baker. Today we're speaking with Dr. HyeRan Choo. Welcome to the show.
Hi, Rachel. Thank you for having me.
Dr. Choo is a clinical associate professor in our Division of Plastic and Reconstructive Surgery and a DDS. Why did you choose teeth?
I had no clue. I was born and grew up in Korea, and when you go to college, you kind of hear what teacher tell you. Like, I think you're good at this, so whatever you get the entrance exam score, and then you kind of go to where you like teachers or your relatives, uncles tell you that it might be a good fit. So that's how I ended up going to dentistry first. I had no clue, really. Thankfully, when I got in there, it was good fit. It had a lot of opportunity to use my hands and come up with some making things. So I think I like making things with hands. So it was good fit in the end.
Nice. Well, so it seems like early on in your career, I was stalking your CV, and it looks like you knew you didn't want to go into like private practice. You received a combined degree in natural sciences and dental surgery from Seoul National University before doing orthodontic residency and a master's at UAB. And yet, I think actually what you're most well known for, at least at Stanford, is a non-surgical approach, something you innovated for Pierre Robin Sequence, which is a rare congenital disease I'd never heard of before. Can you tell us what it is?
Yeah, it's a very complex condition. So it's a clinical diagnosis, not based on the genetic testing. So when you have these three very characteristic traits, which is very small chin, we call it retrognathia, and then glossoptosis is a prolapsing tongue blocking the upper airway, and also have a upper airway obstruction validated by the sleep test. When you have those three, we can diagnose this baby who has a Robin sequence. And even though it's not diagnostic criteria, more than 80% of the Robin babies actually have a cleft palate as well.
Oh, interesting. And so this makes it hard to eat, breathe?
So because of this very challenging anatomies, these babies will experience failure to thrive, meaning like hard to breathe and hard to eat, which are, essentially most important thing in their lives during that stage.
So classic treatment for this appears to be surgical in terms of repairing the cleft palate and distraction osteogenesis, which sounds hella painful, by the way.
So the reason that babies have breathing difficulty is because the tongue blocking the airway. So the goal is to bring the tongue forward. But since there is no way we can bring the tongue forward surgically, we kind of elongate the jaw bone, which has the muscular attachment to the tongue. So when the jaw bone comes forward, hopefully the tongue will come forward. So behind the tongue, that there is more breathing room. That's the concept.
Yeah. Got it.
The hardware is you install on both sides of the jaw, and then you cut the bone in between those, in the middle. So the lower jaw becomes three pieces. So you start elongating those separated pieces. You separate, and then in the middle, on the separated, the gap, will have a regenerated bone. So that's how we elongate the jawbone.
Wow, that sounds really intense. What made you think there might be a better way?
So initially, I didn't see these neonates. I dealt with the kids who comes to my outpatient clinic, and with the complaints of, I can't open my mouth, or my teeth are not growing. I still have a sleep apnea, and I'm thinking to have another. When I say I, means the parents. We need to do another jaw surgery to open up the airway. And then when they smile, they have a skewed smile because one side of the facial nerve is damaged. So those kids come into the outpatient clinic many years down the road, and I was thinking, okay, with the name of surviving, with the name of breathing when they were babies, we had to do jaw distraction surgery, but they have to deal with all these consequences down the road. So if there is any way we can prevent all of it. So that was the reason I started to get more interested in this, doing more non-invasive early on if we really don't have to.
Mm-hmm. Nice. And how does your system work?
My system is that it actually scoops the tongue out of the airway,
Oh.
meaning I don't control the jawbone at all because the primary goal is getting rid of the tongue from the airway.
Mm-hmm.
So when the device goes in, it directly scoops the tongue out of the airway
Mm-hmm.
so the baby can breathe immediately.
Oh.
And when the tongue comes forward, what happens is the muscular connection between the tongue and the anterior portion of the mandible
Mm-hmm.
brought forward as well. So when the tongue is forward, mandible is already forward, and that gives kind of tension to the temporomandibular joint,
Okay.
which is the growth center of the mandible. So that tension, I speculate that's the drive for the accelerated mandibular growth during the treatment and even following the treatment as well.
Well, I saw a photo of your first patient, a little girl named Aliana, who's totally adorable. But I gotta admit, this advice looks like the headgear that I wore in fourth grade. How do you go about fashioning one of these things? Did your degree come with like a minor in metalworking?
So during dentistry and orthodontic residency, we spent a lot of time in learning materials,
Oh.
metal and composite, the plastics. At the same time, we spend a lot of time in learning biomechanics and biophysics and growth and development. So with those tools, then you are very comfortable dealing with the hardware and then chemicals, and you can come up with whatever design you can think about creating.
This is so cool. Now I'm thinking maybe I should have gone into dentistry. This sounds like so much fun.
It's a lot of fun.
Well, so that little girl, your first patient was in 2019. What improvements have been made to the orthodontic airway plate? I think that's what you call it in the last few years.
The important thing is about this treatment is it's not like one person doing it. It is a team approach. It has to the experts from different disciplines have to really synergistically combine their experts to make it work. So initially, I did not have that type of rapport from different departments, but the more I do it and people get to see the changes I was able to bring in, the level of collaboration and then time sensitive effort has improved. I think overall improved the patient care as well.
Excellent. So, are you planning on doing any sort of research or taking images or anything to find out exactly how it's working?
Oh yeah, so we are doing three-dimensional and two-dimensional cephalometric analysis on the jaw growth and overall craniofacial growth and airway, and then the outcome is just fantastic. We're comparing with at the age 12 months old.
Mm-hmm.
These babies' actual treatment for the soap is about a few weeks to a few months. So after that treatment is done, several months later, when they become 12 months old, I have a CT done. And then, so retrospectively, I'm comparing with the healthy controls, 1 year old healthy control CT with the soap treated baby CT.
Mm-hmm.
And then when I look at it, they are almost really like airway is normalized and the jaw growth is normalized. So it's very promising outcomes are coming. We just don't know what's the mechanism behind it.
Well, so as of September of last year, you had treated 25 babies with a 100% success rate. What are you thinking your next steps are going to be here?
Next step for this program is still it's been only like 3.5 and 4 years of it's the infancy stage of the program, and especially it requires you know very delicate collaboration from many different departments.
Mm-hmm.
Still, we are in the stage of developing more rapport and then producing a lot of data to make this treatment more available and then aware by other professionals as well. The interdisciplinary approach comes from neonatology, otolaryngology, nursing, infant feeding, which is rehab services, and orthodontics and plastic surgery, sleep medicine.
It's a lot of people who are involved.
As well. Yeah, a lot of, and yeah, genetics as well, of course.
Wow. I'm wondering, because it's a purely Stanford program right now and it requires, with so many team members, how do you recreate this at other hospitals?
I think that's going to be the biggest challenge. Actually, last week I was in Mayo. Mayo Clinic asked me to come and talk to their interdisciplinary team because they're really interested in this program. But you need to overcome two things. One is operational sensitivity, meaning that there is some intricacy that as an operator, the sensitivity level is different. So that makes it challenging. Another thing is institutional resistance. I think that the institutional resistance, it has the biggest hurdle that I've faced here because it's such a new concept that a lot of people don't either not willing to try or not willing to even accept.
The babies, they have to be at a certain age, is that correct, so that you can treat them?
Yeah, definitely within 3 months. They have to be very young. The sooner the better, right after they're born.
Got it. And if it doesn't work, you can always do the surgery later on?
Within a week or so, we can tell if it's going to work for the baby or not. There are other surgical options always available, and surgical complication rate goes down when the babies are older. So let's say if you do the same dissection surgery within the first year, complication rate is about 26%. But if you can do that surgery after 1 year old, complication rate goes down to close to 11%. So delaying the surgery itself has the big value.
Understood. All right. Well, so we're about out of time, so I want to ask our final two questions. On each episode of Scrubcast, we ask our guests these two questions. And the first one is, who is a surgeon you admire and why? Or I suppose you could choose a dentist.
Yeah, Dr. Park, he was my mentor and still is. And he was the one actually who told me that, hey, HyeRan, I don't think you're going to do well in Korea. You should think about going outside country. So he is one of the most skilled and also deepest understanding about human being, about who we are and why we are here. Kind of very philosophical understandings about humans, and then which motivated me to continue to do what I am doing for very rare conditioned patients as well.
Wonderful. Well, and the second question is the best advice you have received in 10 words or less.
It's also from Dr. Park, and he told me, be grateful to be in a position that you can help others.
Oh, that's really sweet. I love that. It has been a pleasure talking to you. Thank you so much for coming on the show.
Thank you very much for having me.
And that brings us to the end of another episode. If you like Scrubcast, we hope you'll tell your friends and subscribe wherever you get your podcasts. Scrubcast is a production of Stanford University's Department of Surgery. Today's episode was produced by Rachel Baker. The music is by Midnight Rounds, and our chair is Dr. Mary Hahn.